Good afternoon, everyone. My name is Kristina Gemzell-Danielsson. I will be the chair of this webinar, and we will focus on estrogen matters, Estetrol in combined hormonal contraception. So thanks to Gedeon Richter, who is sponsoring this webinar. And the webinar presentations will be recordings from the last European Society for Gynecology meeting. But importantly, it will be followed by a live Q&A session. The speakers today is myself, and followed by Franca, Fruzzetti, Professor, and then Professor Terhi Piltonen, Professor Jonathan Prof, and we will all join for the last Q&A session. Then we also have a presentation by Professor Tommaso Simoncini, and unfortunately, he will not be present during the Q&A session. So with this, we will move on to the first presentation, and that is a presentation by myself on compliance for real-life effectiveness. A warm welcome to all. Compliance for real-life effectiveness. These are my potential disclosures. Yeah, so I'm also director of the WHO Collaborating Center at Karolinska Institutet, and I'm member of the International Committee for Contraceptive Research at Pope Council, in addition to these disclosures. So I think we need to start with asking ourselves, is there a need for new contraceptive methods? And well, if we look around, globally, more than 200 million women in partnership lack access to effective and acceptable contraception. So that leaves another millions of single women and men. And we know that the consequences are worse in low-income countries with poor healthcare, but actually, on an average, the unmet need is calculated to 10%, and in Sweden we calculate it to 17%. We know that consequences, as I said, may be severe, like maternal mortality and morbidity caused by unsafe abortion, but it may also severely impact quality of life. So I think the answer to this question is yes. So now, how would we design a perfect combined or hormonal contraceptive? Well, progestins forms the basis, and depending on the dose, with high enough dose, it will inhibit LH release and thereby inhibit ovulation. And progestins will also cause thickening of the cervical mucus and thereby prevent sperm motility and function. So, but then if we really want to improve compliance, we should also add estrogen, because estrogen will increase concentration of progesterone receptors in the endometrium, and this contributes to better bleeding control. And it will also inhibit FSH release, which inhibit development of the dominant follicle and further contribute to inhibition of ovulation. So, and estrogen is an essential hormone. We know how important it is for bone mineral density, for brain, cognitive function, eyes, teeth, blood vessels, circulation, breast, colon, urogenital membranes, and also for skin and wound healing. But the most important is for bleeding pattern. So now, which is the most common reason that someone will quit their contraceptive method? Wish for pregnancy, which is highly acceptable. But otherwise, most common is actually poor bleeding control. So bleeding control is extremely important for compliance. And here, if we summarize, Estrogen maintains the menstrual cycle and good bleeding pattern. It prevents estrogen deficiency symptoms such as vaginal dryness, and which has a detrimental impact on sexual health and function. And it builds and/or maintains adequate bone mass. So in contraception, it assists the progestin component in inhibition of ovulation, so contributing to high efficacy and compliance. So we have this delicate balance. Estrogen will increase compliance, efficacy, and overall effectiveness. On the other hand, we know that it's also linked to safety concerns with arterial and venous thromboembolism. Now, if we do a quick historical overview, already when the first pill reached Europe, Anno Blar, the estrogen component had been reduced. So ethinyl estradiol had been reduced, but still high levels. At this time, as you can see here, it was only married women with approval of the husband who got access to the pill. So fortunately, we have moved a long way since then. And well, it may be a good idea to include a partner for compliance, but fortunately now women are empowered to make decisions on their own life. But over the years, it's been recognized, as I said, that the estrogen dose is associated with the risk for thromboembolism, and the dose has been gradually reduced until we have reached sort of a limit where the ethinyl estradiol component cannot be further reduced without increasing irregular bleeding. So then scientists turned to natural estrogens. And natural estrogens, first it was estradiol E2, then now recently followed by Estetrol E4. They differ to ethinyl estradiol in many ways when it comes to metabolization, bioavailability, and sustainability of biological action. So the different effects on reproductive organs, that is the uterus, and the non-reproductive organs, that is the liver, where we really want to minimize the effect. And we can see here that 1.5 milligram of E2 or E2 valerate, when it comes to the liver effect, corresponds to just 3 to 5 micrograms of ethinyl estradiol. If we look at E4, the potency of E4 is 100-fold lower than that of E2. The mode of action of E4 estetrol is completely different compared to the other estrogens. And it binds mainly to the ER-alpha receptor. On the ER membrane, ER-alpha receptor, it acts as an antagonist, which is unique. And that means that it has a neutral effect on the liver, unlike other estrogens, and also on the breast, and this includes malignant breast. When it comes to the nuclear estrogen alpha receptor, E4 acts like a classical estrogen as an agonist, and that means that it activates the nuclear ER-alpha receptor, resulting in estrogen activity in the vagina, endometrium, bone, and cardiovascular, so where we want it to achieve high compliance and added health benefits. E4 is also unique when it comes to its pharmacokinetic profile compared to the other estrogen components in combined hormonal contraception, E2 and EE. In that it has a high oral bioavailability, it has a relatively long half-life, so this combined results in ideal situation to be administered like an oral once-a-day pill. It doesn't have any high binding affinity to SHBG, which also have potential positive impact, and only minimal SHBG production in the liver, reflecting the low sort of activity when it comes to the liver. It has no active metabolites, in contrast to the other estrogens, which means no risk for potential carcinogenic metabolites or estrogen reservoir. And it's not metabolized by the CYP450 enzymes in the liver, which means that there is no risk for drug interaction. Now, E4 is also possible to combine with an anti-androgenic progestin, such as drospirenone, which has many positive effects that will also further improve compliance. I mean, we know that drospirenone has anti-mineral corticoid effects, which will prevent sodium and water retention, and with that prevent weight gain, edema, and breast tenderness. It has the anti-androgenic effect, which will be favorable for when it comes to acne or seborrheic problems. And it has pronounced progesterogenic effects, which means that it has good ovulation inhibition and reliable cycle control. And in addition, it also has a long half-life, which will again be beneficial in case of slightly poorer compliance occasionally. And E4 drospirenone combined results in a highly predictable bleeding pattern, as you can see here, with over 92% of women having scheduled bleeding. So, taken together, the first oral contraceptive with Estetrol, which is a native estrogen with selective action, works differently to all other estrogens. It keeps the advantages with estrogen in the combined method when it comes to compliance, efficacy, added health benefits, the overall effectiveness, while balancing safety issues. And I think based on the data we have, that we will hear about here, that it is time that we revise our clinical guidelines. Thank you. So, following this start, we will move on to the second presentation, and that is given by Professor Franca Fruzzetti. She is professor at the University of Pisa in Italy, and her her focus is reproductive endocrinology and fertility control. She has conducted research on hyperandrogenism and hormonal contraception, and she's a member of many scientific societies, including the International Society of Gynecological Endocrinology, Italian Society of Obstetrics and Gynecology, the European Society for Contraception, Reproductive Health, and Androgen Excess Society. And she has also many other scientific tasks. So her presentation, the title is Women and the Right Estrogen, an indissoluble combination in contraception.
And okay, so these are my disclosures. Okay, Kristina stressed very well the importance of estrogen in hormonal contraception, and so at this point the question is which is the best estrogen. And obviously everybody knows that estrogens may have a very important role in the women's well-being because they exert many positive effects on many tissues, reproductive and non-reproductive tissues. But obviously Estrogens may also give some problems and some other risks related to the effect of estrogens in general on breast and on cell proliferation and on coagulation, inducing a possible increase in the venous thrombosis. So which is the best estrogen? Is the estrogen able to maintain the benefits and avoid, obviously, possible risk? And at the present time, you have in our available 3 kinds of estrogen: ethinyl estradiol, a synthetic one, natural estrogen, 70-beta estradiol, and estradiol valerate. Remember that the estradiol valerate, after ingestion, is transformed immediately in E2, and estetrol. And very quickly, estradiol is a synthetic estrogen. It is resistant to the rapid metabolism during the first pass through the liver, so it remains in the circulation for a long time at high concentration. Because of this, it exerts a very important estrogenic action on estrogen receptor, and also ethinyl estradiol has a high impact on the metabolic pathway at the level of the liver. And looking at the negative markers, also you can see that ethinyl estradiol may induce an important increase in angiotensinogen, so have a possible effect on blood pressure and on coagulation. So looking at this possible risk, there is the need to move to other kind of estrogens. And the natural estrogen, E2, exerts its estrogenic action on estrogen receptor alpha and beta. It is very rapidly metabolized at the level of the liver, so the bioavailability is very low, and it exerts a lower effect on estrogen receptor and on the metabolic pathway lower than ethinyl estradiol. In fact, as you can see, the increase of angiotensinogen and coagulation factor is lower than with ethinyl estradiol. But at the level on endometrium, E2 may have some problem. The problem is that when E2 is associated with the progestin, there is an activation of the 17-beta enzyme that rapidly change the E2 in estrone. And estrone is a weak estrogen that, acting on endometrium, is not able to induce a very good proliferation of endometrium. In the endometrium there is an insufficient local estrogenic effect because the presence of high concentration of estrone, and so you can have endometrial instability. And because of this, in the clinical practice, E2 has been associated, or estradiol valerate and E2 has been associated with the progesterone with a very important effect on progestogenic activity on the endometrium. And as a consequence, when you check their capability to induce a good cycle control, what we can observe that there is the number of scheduled bleeding has been reduced. There is an increase with natural estrogen pills of the possibility of amenorrhea, and you can see the percentage is about 20%. And also you can have the appearance of a scheduled bleeding, such as breakthrough bleeding on spotting in a percentage move from 20-30% per cycles. And because of this, the different studies show that the discontinuation rate for a power cycle control, so for problems related to the bleeding, is high from 15 to 27%. And I remember that with ethinyl estradiol, the percentage of discontinuation was very low, about 5%. So the change from ethinyl estradiol to E2 increase the rate of the discontinuation related to irregular bleeding. So when you put on the balance, obviously the introduction of E2 has been followed by a higher metabolic safety, but we may have some problems, so critical problem on the cycle control. Estetrol. Estetrol is a new kind of estrogen, and it acts only on the estrogen receptor alpha, but it is able to maintain the estrogenic effect. Estrogen alpha are very well represented in many tissue, and because of this, estetrol is able to maintain the estrogenic effect of estrogens in general on the brain, is able to prevent bone demineralization, so is able to maintain bone mineral density, and at the level of uterus and vagina, as you can see, estetrol is able to induce the growth of uterus, so positive effect, and to maintain also proliferation of the vaginal cells and lubrication. And estetrol also is able to maintain the positive effect of estrogens at the level of vascular wall, so it is able to maintain the vascular protection of estrogens, and the different experimental studies show that is able to prevent the formation of ateroma or intimal hyperplasia. At the level of endothelial cells, E4 is able to induce vascular remodeling and regeneration, and at the level of the arterial is able to protect the arterial, induce peripheral vasodilatation, to prevent also the effect on over hypertension. And a very interesting effect can be observed when you look at the effect of E4 on the mammary gland. And as before has been very well described, estetrol acts on nuclear estrogen receptor alpha, but not on estrogen receptor present on the membrane. And at this level, estetrol is able to antagonize the effect of other estrogens. So it is able to block this kind of receptor. So moving from the biochemical to the clinical, to the experimental study, what is observed that E4 in the normal mammary gland is able to stimulate proliferation, but the proliferation of cell induced by E4 is very low and lower than E2 and ethinyl estradiol. Moreover, when in the experimental study estetrol has been administered with E2, estetrol is able to reduce the proliferation induced by E2. So it is able to exert an opposite and antagonist effect on the action of E2. And this is for the normal breast, but you are available data also on the mammary with the breast cancer. And as you can see, E4 is able also to decrease in rats the volume of the breast cancer, and in culture of human cells from breast of women, as you can see, E4 reduces the migration and invasions by breast cancer human cells. And in a very interesting study performed on women with breast cancer, estetrol has been administered 14 days before surgery, and after surgery the tissue has been examined, and as you can see, in women treated with estetrol there was an increase of cell apoptosis. So I think very particular effect of estetrol not shared by other kind of estrogens. And by acting only on one kind of estrogen, also at the level of the liver, estetrol is able to stimulate, but a very low stimulation of all markers of metabolic markers of coagulation, lipids, androstensin, sex hormone binding globulin, and other particular pharmacological property of estetrol. Estetrol is not a substrate for the enzyme or cytochrome P45, and also is not transformed in estrone. And this is very important. It is very important because the absence, the lack of a transformation of estetrol into estrone may have very important clinical consideration. And first of all, at the level of coagulation, remember that estrone may have an impact on hemostasis inducing coagulation, so the lack of conversion could reduce the procoagulant effect of this kind of estrogen. And at the level of endometrium, there is no transformation of estetrol in estrone, so estetrol is able to exert its estrogenic stimulatory effect on endometrium, so we can have a more stabilized endometrium. And in the clinical practice, estetrol has been associated in a 24 regimen with drospirenone. And as far as the cycle control, on the right, there is the effect of drospirenone alone on cycle control, and on the left, when to drospirenone we added estetrol. And as you can see, the addiction of estetrol is able to normalize the response of the endometrium. In fact, if you look at the incidence, the presence of scheduled bleeding, as you can see with the drospirenone only, you have less than 50% of women have irregular scheduled bleeding, whereas if you add estetrol, the percentage is very high, more than 90%. And as far as the incidence of irregular bleeding, we can have a percentage, some irregular bleeding. The percentage, as you can see, is lower than 20%, is higher in the first months and after the decrease, and obviously is lower than that induced by the drospirenone only pill. And when you compare the cycle control of the association with the estetrol with the cycle control exerted by the pills with the natural estrogen, also in this case you can see that the presence of scheduled bleeding is higher with the pill with the estetrol. And as far as the unscheduled bleeding is the incidence of spotty and breakthrough bleeding is present with estetrol also, but is slightly lower than with the other E2 pills. And as far as the tolerability, the adverse events reported in a phase 3 study, as you can see, is very low. But I would like to draw your attention on the discontinuation. In particular, as you can see, only 2.8% of women withdrew from treatment because of irregular bleeding, so a very low percentage of women. And also the discontinuation because other signs such as acne, libido, and so on, as you can see, is very low. And as far as metabolic, the study show a metabolic safety. This will be discussed later by my colleagues, so I move on. So what happened moving from ethinyl estradiol to E2 and E4? What changes? So as far as the estrogenic benefits, you can say that estetrol maintain moderate estrogenic effect on all estrogen-sensitive important tissue, lower than ethinyl estradiol. As far as the breast, estetrol exerts an antiestrogenic effect on mammary gland, completely different from the action exerted by the other estrogens. And as far as the metabolic safety, estetrol have induced minimal estrogenic impact on the liver, not as strong as the one exerted by ethinyl estradiol, and at the end is not metabolized to estrone, a weak estrogen, so the endometrium is much more stable. And so you can, in our practice, we can use this kind of association with the estetrol, I think, from adolescence to perimenopause stage. But if can be considered the right estrogen for all women, this is my personal opinion. You can discuss about this, but I don't think that in tailoring contraception, no one size can fit all women. And so now I think, this is my last slide, that in our clinical practice we have the possibility to prescribe, to tailor our contraception, taking into account the request of the human profile, what women want from contraception. And you cannot exclude one estrogen and instead of the other. So we need of all kind of estrogens. And obviously, if you have women with a severe or moderate, from moderate to severe acne, so women with hyperandrogenism, we can use natural estrogen, estrogen, but probably the choice should be better to use pills with ethinyl estradiol, looking may have a higher increase in sex hormone binding globulin and so on. Our focus is the metabolic safety. Natural estrogen and estetrol obviously should be the first choice. If you look at endometrium, some women don't like to have irregular bleeding. They like to have a regular menstrual cycle. So probably the pills with the 30-35 ethinyl estradiol is okay. But now you have also the possibility to use a natural estrogen such as estetrol. And your focus is to reduce the symptoms of hyperestrogenic symptom referred by the women. Obviously, our first choice will be natural pills with natural estrogen and estetrol. And many women have a concern about the breast. Obviously, now we have no data. But the first study, the study in vivo, in vitro in animals, and the first observation in the experimental in women, I think that probably take into account this possibility also estetrol in this kind of patient may be an option. Thank you very much for your attention.
So just a reminder to post your questions in the Q&A chat. And if you want, it's good if you stay to you are. And also if you want to direct a question to any specific speakers, or you can just ask in general. So please take the chance, and thanks to those who have already used this possibility. So we will move on to the next speaker, who is Professor Terhi Piltonen, who will address estetrol-based contraception, insights from estetrol-drospirenone clinical trials. And Professor Piltonen is a neighbor to me. She is a professor at the Department of Obstetrics and Gynecology in Oulu in Finland, so not far from Sweden. Her team has focused on the lifelong health in women related to gynecology and obstetrics, especially focus on PCOS, endometrial function, and health and hormonal contraception. She is past associate editor of a number of scientific journals and currently co-editor-in-chief of the seminars in reproductive medicine. She's the president-elect in the AEPCOS Society and the scientific committee chair of the Nordic Society for Obstetrics and Gynecology. And by the way, the next NFOG conference will be in Sweden, in Uppsala, next year. So it's my pleasure now to start Professor Piltonen's lecture.
Here we are going to concentrate more on the endocrine or the metabolic effects of estetrol, and there have been some mentioning in the earlier presentations, but let's go and move and look at a little bit more closer to the clinical trials that have been actually carried out on estetrol. So these are my disclosures, and I have to underline also that most of the data from my own team, it's researcher-initiated studies. So why do we need new preparations on the market? I think we all agree that, you know, development is very good, and we do need to develop all the time, and that's why we are here, because there is a development step that has been taken. So here, this is the reason why we are talking about metabolic outcomes. I think very often when we are seeing our patients, we are thinking about contraception and the efficacy and things like that, and just making sure that it's a pill that will take care of what it's supposed to take care of. But on the other hand, if you think about that now, this is the data from Europe that the women are having 1.6 child during their lifetime. And I think you were yesterday maybe hearing Bart's wonderful presentation. It doesn't look like that this is going to rise. So this will mean that the women will use contraceptives. There is a need for contraception for quite many years. So the ones that we are prescribing to the women, it will actually have an impact as they are using them for quite some time. Now, this is also something that we need to consider, that as they are using these contraceptives for quite some time, women are living longer. So the girls that are born now, their life expectancy is 84 years. And as you see from the Eurostat, if we have the conditions as we have now, let's hope that we do, the life expectancy is going to be even longer. So all the interventions that we're going to have for the women during their reproductive life, it's going to be reflected for the later on their life, because they need to live with those health outcomes for a very long time. Many times we're thinking, why are we talking about metabolic? Of course, we know the obesity epidemic in the world that is also affecting women, but many times I think we consider that cardiovascular diseases and the outcomes are actually men's diseases, but that's not the case. This is the studies from Europe showing that actually the CVD mortality is the #1 cause for mortality both in men and women, and they are piling up here. As you see, stroke, ischemic heart diseases, and diseases in circulatory system. So we have to really pay attention that how early and what sort of a prevention strategies we are able to provide for the women so that they will have also healthier CVD outcomes later on. This is a study from UK, and this is quite interesting approach. They were looking at these reproductive health outcomes at a young age, and then how did they associate later on with the cardiovascular outcomes during the upcoming years. And there are 32 papers that they included in this review, and I'm going to show you just this outcome. This is about ischemic heart diseases. And you'll see there are lots of the things that we know that are risk factors for cardiovascular events: early menopause, gestational diabetes, for example, preeclampsia, we know that's a risk factor, polycystic ovary syndrome. They're very known factors. We know that they are metabolic risk factors. But actually, if you look at the data, there is also combined contraceptives there that seem to be translating, or they are associating to increased CVD risk. But what we need to also think about here, if you look at the data, there is lots of heterogeneity in this data. And that means that there is some fuzziness inside the data, and that most likely reflects that there are different progestins and also doses of estradiol, ethinyl estradiol in that data. And then natural estrogens are definitely underrepresented in this data set. So how can we then improve? If women are using these preparations for a long time and we need to protect them and think, what are we really offering them? How can we improve the metabolic effects in the long run? Our team has been trying to answer this question. We have been pondering this for quite some time, and what we have been trying to think whether administration route, if you change the administration route, is that something that you could change the metabolic outcomes, or then if you change the estrogen. And this is one of our early studies, as you see, it was a quite long time ago when it was published. So here we thought this idea actually came from the hormonal replacement therapy field. So there you all know that if you administrate HRT transdermally, it has lower impact on the chronic inflammation compared to oral administration. So we thought that maybe here, when these transdermal and vaginal preparations were coming to the market, that maybe they are metabolically more beneficial for the women and we could recommend them. So this is a pilot study. The number is not very, but I think it's a very good study in that sense that you'll see what happens, because these are very young, young women, just healthy, there is nothing wrong with them, they are normal weight. So we just wanted to look at what are the metabolic outcomes. And here are the results. So what we did was that we administrated 9 weeks. It was a continuous use, no breaks, continuous use for 9 weeks. And this is the HOMA-AR, so this is insulin resistance. So you'll see that during the 9 weeks, the women develop a mild insulin, more insulin resistance during that time. And then what I like to highlight is the chronic inflammation that we have here. So the chronic inflammation was increased during the 9 weeks of use. It didn't matter what was the administration route. And also the lipid profile, especially the increased triglycerides. We know that they associate with the cardiovascular risk outcomes later in life, so these are quite important that they were actually increased in all of these. It didn't matter. So the conclusions here was that I don't think we can save women by changing the administration route. The EE is very potent. It doesn't matter, and it passes the first pass metabolism from the liver, and it circulates very with the high concentrations in the circulation. So you can't really escape it. So here, this was our second try. So here now we wanted to look at the natural estrogen. So we ended up picking estradiol valerate. Here, Estetrol was not an option at that time, so we did estradiol valerate, EE, and then Dynagest only, and you'll see that the dose for the EE was 30 micrograms here. And again, there were 9 weeks, continuously, no breaks. And this is the only slide from that. We have published several papers, but I think this is the most important paper that we produced from this, showing that if you look at the proteomics, so this is systemic, it's a serum sample that was run in mass spec analysis, and you look at the proteome that you present in your bloodstream, and we compared this before and after the treatment. And you'll see that at 9 weeks, the women that were on ethinyl estradiol started clustering significantly when you compare all the women. And here, if you look at what was the change of proteins that were differently expressed after that 9 weeks, it was over 140 proteins that were expressed differently after the 9-week treatment, whereas you see that it's quite minimal for these two other preparations. And the proteins that were involved were actually, they were thrombogenic, they're inflammatory proteins, and the ones that are affecting the renin-angiotensin-aldosterone system, the one that is regulating the blood pressure. So I think it was quite worrying in that sense that, we are able to exert all this, but on the other hand, we are very excited that, now it does look like that, changing the estrogen, it does seem to make a difference. So that's why we are now talking here today. So there is another option as well to think about this with Estetrol. And these are the studies that have been conducted. We are going to talk about the phase 2 trials because they actually include those metabolic function targeted studies. And then I have to say that we did, my team participated into the last trial that was run in EU. So here, of course, if you think about long-term usage of these preparations, I think, as it has been already announced on the earlier presentations, that compliance is very, very important. And and of course, coming as a new product on the market, you need to be, it has to be very effective product to be accepted. So definitely, we already heard that the contraceptive efficacy is very good, and the bleeding profile is very good. So the tolerability is good, and there is a very low discontinuation rate because most likely the very good bleeding pattern and also other adverse event was very low. And then what I think metabolically, I think is very important that also the women with BMI over 30 seem to benefit from this. So also they had good efficacy for this preparation. These are the 3 different preparations that were compared. So Estetrol against the 30 microgram EE and then 20 microgram EE, and that had the same drospirenol dose as the Estetrol. First, let's look at the glucose metabolism. So you'll see that this is at the baseline, and this is after 6 cycles, and it does look like that there is no effect. If you'll see that the lines are almost the same during this OGTT, so I think we can conclude that there is very little or no effect on glucose metabolism, or we have to say there is no effect on the glucose metabolism during this 6-cycle use. So then there we can kind of be safe. If we look at the lipids, I think I want to highlight the fact that with the EE, with the 20 microgram dose of 20 micrograms of EE plus drospirenone, that had 60% increase in triglycerides during that 6-cycle use. And then if you look at the estetrol, it was about 20%, so it was significantly lower. And thinking about the overall effect, if you look at the whole these lipoproteins, there is also a trend that it's a very minimal effect with the estetrol on these proteins, and that is a good sign. And even though coagulation system, there's going to be a really wonderful presentation in a minute, but I'm just going to very briefly say that, of course, because coagulation system is part of this vasculature and it's very much affected, I'm just going to tell you quickly that if you look at that, the profile is completely different. And then in the next slide, I'm going to show you the SHBG. So this is the liver function. So the corticobinding globulin, cortisol binding globulin, and then sex hormone binding globulin, they were quite minimally affected by the E4 compared to EE. And then, of course, if we think about cardiovascular outcomes, you have to think about angiotensin. This already came up with our own study with the natural estrogens, that the angiotensin was one of the proteins that came up from the proteomics analysis. So this has to be reminded, thinking about the risk for hypertension or elevated blood pressure. So as a summary, I think we can say that estetrol is combined with the drospirenone is an effective contraception with a good tolerance. It has only neutral or minimal effect on lipids, glucose, and liver function, and that all the metabolic outcomes that I've shown you, it might be that it would have a beneficial effect in the long term as for metabolic outcomes. Thank you.
So thank you for posting questions, and please remember that you can post them already now in the Q&A box. It's nice if you state your name, and if you want, you can also state who the question is meant for. So we will move on with the next speaker, who is Professor Jonathan Profi. He graduated in pharmaceutical sciences and then earned his PhD in 2015. He founded Corley Blood, a CRO providing blood investigation services for clinical trials. And in 2018, he began teaching pharmacology at the University of Namur, where he is now a professor appointed in 2023. His research focuses on thrombosis, and he has developed an algorithm to assess hormone-related prothrombotic changes, earning him the Eberhard Mammen Young Investigator Award in 2019. And during the COVID-19 pandemic, he led projects evaluating diagnostic assays and investigating thrombotic risks in COVID-19 patients. He's also working for the European Medical Agency, and his work has influenced guidelines for the measurement of direct oral anticoagulants. His presentation is entitled Hemostasis Parameters with Estetrol Drospirenone, Why APC Resistance Matters.
So these are my my disclosure. Okay, we are here today to speak about thrombosis, and probably most of you know that thrombosis is a multifactorial disease. obviously, when we are taking the pill, we know that we can increase the risk of thrombosis by 2 to 8-fold. But it's not the only factor. It's not the only factor. Obviously, the age will also increase the risk of thrombosis. The fact that being pregnant, obesity, taking a flight, being ill, also genetic factors are also quite important when we are speaking about thrombosis, and also being at rest may also be a problem. But here today we are focusing mainly on the intake of combined oral contraceptive. From the literature, the very old literature, we know that the risk of VTE will increase with the dose of 18-estradiol, and we will also see a decrease in the risk of VTE by increasing the androgenicity of the associated progestin. This led, quite interestingly, to an important referral from the European Medicine Agency. It was 10 years ago. And in this referral, there is a famous table. This famous table is just reporting the incidence rate that you can expect with different associations. And the risk, obviously, we all know that the risk will change considering the associated progestin. But there is one main issue from this table. The main issue from this table is that all the data that are captured in this table are only based on combined hormonal contraceptive containing 18-estradiol. Then, in the 20s and the early 2010, we saw some new products with estradiol coming on the market, and these new products already also in all the literature 15 years ago, they demonstrate that there was a lot of investigation on hemostatic factors, and they demonstrate that based on the lower impact of estradiol and estradiol valerate on the hepatic system and subsequently, obviously, on the hemostatic system, as it was demonstrated by the very interesting, and I really love the study on the proteomic. It's really amazing, and I really like that. But obviously, the impact that we have on the hemostatic system will be lower compared to 18-estradiol, and it is assumed then that E2 and E2 valerate are associated with a similar or even a lower risk of cardiovascular event, including venous thromboembolism, compared to 18-estradiol. And this is mainly based on a reflection, which is the progestin-estrogen balance. Obviously, when we are speaking about a balance, it depends on the potency and the dose of the estrogen component, but we have to think that this estrogen-progestin balance is modulated by the androgenicity of the progestin. And here I just take the example of 18-estradiol with dienogest versus estradiol valerate plus dienogest. It is to make a link with the previous presentation, but obviously if we are changing the estrogen, replacing 18-estradiol by estradiol valerate, for example, we are restoring a quite well-balanced progestin-estrogen balance. And then we are moving to the epidemiological data. So it took more than 7 years to get these data from post-authorization safety studies. And we have two famous data from the INASCOR and the PROE2 study, which revealed that, and these studies were not powered to demonstrate a superiority of estradiol-containing product, just a non-inferiority compared to 18-estradiol levonorgestrel based on the request from the European Medicine Agency. And what we saw, it is that for E2 valerate dienogest, we have a reduction of the risk of VTE compared to other combined oral contraceptive, which is a gathering of all the other combined oral contraceptive in this study. We have also a reduction. This is not statistically significant, but we have a reduction compared to levonorgestrel containing combined oral contraceptive. So this is quite interesting to see that even if the result is not statistically significant, it is probably due also to the lack of power in this sub-analysis of the INASCOR study. But we have a point estimate which is very close to the one that we have for other combined oral contraceptive, demonstrating that E2 containing product, here E2 valerate in association with dienogest, may have a lower risk of VTE compared to 18-estradiol containing product. And this is exactly the same, also due to a lack of power as well, but we demonstrate a non-inferiority compared to 18-estradiol levonorgestrel, but also the point estimate is below 1. So it means that if we are replicating this data into a larger population, probably that we will reach the statistically significance, and that we may probably change our way to see the safety of combined oral contraceptive, because up to now, the European Medicine Agency is just saying that 18-estradiol levonorgestrel is the safest combined oral contraceptive, but probably that it's not true, not longer true, and probably that natural estrogen are safer than 18-estradiol levonorgestrel. And it is also interesting to see that in 2005, the European Medicine Agency requested a lot of investigation to be done for the development of steroid combined oral contraceptive. And they provide a list of several factors that need to be assessed. These factors are mainly factors for the coagulation, from the coagulation cascade. And they recommend hemostasis investigation. To be honest, I was not aware that SSBG was a factor of coagulation or in the hemostatic system, but let's say they report that we need to assess that because we can see an increase or a decrease in all of these factors, and this is expected with all combined hormonal contraceptive. And I will specifically focus my presentation today on a specific factor, which is the ETP-based APC resistance. This test has been developed 25 years ago. It was never standardized up to now, but this test has been used to demonstrate that we have an important impact on the coagulation system. So we were speaking about proteomic, the change in all the protein from the coagulation cascade, but here this is a test which is very, very interesting because we are observing all the interaction of all these coagulation factors together. So this is a very important point to raise. So this is really a global coagulation test which is able to see the additive contribution of all the small changes that you have in the coagulation factors. So this test is very, I would say very simple, but it's not I'm a lab guy, so for me it's easy. It's the same for you when you are speaking about your patient. It's easy for you, it's not easy for me. But here the test is really able to demonstrate something which is important. This is, sorry, with this curve here, what we can measure the concentration of thrombin over time in the test sample. So the higher the thrombin, the higher the risk. And we have two specific conditions. We have one condition in absence of activated protein C. So it means that this first condition is not being to check the resistance towards activated protein C. It's just to see the global effect of combined oral contraceptive on the coagulation factor. So you will have, for example, an increase in factor 8, an increase in prothrombin, an increase in factor 10. You will be able to see that in this first curve. And then we have a second curve. In these second conditions, we will put activated protein C just to check whether we have a resistance or not. And this is important to see that, because in a normal sample, you will see an important decrease in the area under the curve. So here you have the thrombin in absence of APC, so you will see all the small changes that can be due to the intake of combined oral contraceptive, and here, this curve is then present to assess the resistance toward activated protein C. So we are doing a lot of calculation. I will not go into so much details about that, but what is interesting is that we use this calculation just to make the result quite simple to understand. So the result will be provided from a scale from 0 to 10, and the lower, the better, the higher the resistance towards APC you have, and therefore the higher the risk of VTE. And this scale is very simple because this is a scale from 0 to 10. So the higher the NAPCSR, the higher the risk. Here, just for the representation, this is a lady on 18-estradiol desogestrel. And this is very interesting to see that, as I mentioned, here you are able to see all the contribution that you have for the small changes in the procoagulant system, so the small increase in factor 7, the small increase in factor 8, and etc. And then you are able to see the resistance towards the activated protein C condition. So here you see that with combined oral contraceptive containing 18-estradiol, you will have two impacts. First, you generate a prothrombotic state by increasing the coagulation factors, and also you generate a resistance towards activated protein C because activated protein C is no longer able to downregulate the generation of thrombin. And obviously we will get, an NAPCSR which is in the middle, so 4.10. We already have a kind of resistance towards activated protein C in this case. Just for your information, this NAPCSR is probably higher than the mean NAPCSR that we have with factor V laden. Just also to make the things quite interesting in the way we will develop the next slides, the NAPCSR, we were thinking that the NAPCSR could be a predictive tool for the risk of VTE. And we were not the only one to think about that. 10 years ago, another group already proposed the use of the NAPCSR as a potential marker to predict the risk of venous thromboembolism in the field of combined oral contraceptive. But we did the job. We did the job, and how we did the job, we assessed the NAPCSR in more than 350 ladies on different combined oral contraceptive. We grouped them according to the combined oral contraceptive, and we compared the NAPCSR. We compared the NAPCSR with the relative risk of VTE extracted from a meta-analysis from the Bastos, which was a Cochrane meta-analysis for the risk of VTE associated with combined oral contraceptive. And what we did is that here, for example, we have no COC. No COC, you have a very low NAPCSR, around 1.5. It is normal that it's not 1 in ladies because women, you are already at a certain resistance towards activated protein C compared to men. But we can see we have the two curves, so the curves to see the impact on the procoagulant system and the resistance towards APC. This is the normal curve in ladies. Then you put a lady on 18-estradiol 20 microgram plus levonorgestrel 150. We have an APCSR around 3.5, a relative risk of VTE around 2.2. Here, just a short reminder regarding the estrogen, the estrogen-progestin balance. We have 18-estradiol 30 microgram, levonorgestrel 150. We increase the dose of 18-estradiol, but we also increase the level of levonorgestrel. We are able to counterbalance the increase of 18-estradiol. We can see that we have practically the similar results of EE 20, levonorgestrel 100. And the NAPCSR is quite the same. The relative risk of VTE is also very similar. Then we have 18-estradiol 20, desogestrel 150, 18-estradiol 30, desogestrel 150, 18-estradiol 35, cyproterone acetate 2 milligram. And then you can see here that you have a kind of association. So the higher the NAPCSR, the higher the relative risk from epidemiological data you may have. This is interesting then to see that we were able to interpolate all of the risk from this model. And this is important because the idea was really to use this model to predict the risk of VTE for associations for which we do not have yet epidemiological data. And this is exactly what we did, for example, with 18-estradiol dienogest, estradiol NOMAC, and E4 DRSP. In the meantime, in 2020 and 2021, we get the results for 18-estradiol dienogest. Here, from the literature, we were able to see that compared to non-user, we have a relative risk of VTE of 3.42. The model predicted a risk around 3.57. The confidence interval are overlapping. Then we check E2 NOMAC. For E2 NOMAC here, we have from the model 1.68, and from the data coming from the literature, from epidemiological studies, 1.58. Obviously, up to now, we don't have data for E4 DRSP, but we have here the interpolated risk from the model, which is very low and which is very similar to what we can have with E2 containing products. So this is really interesting to see that this model is certainly able to predict the risk that we may have with a specific combined oral contraceptive. And just to demonstrate here the data that we obtained, so we obtained for EE dienogest an APCSR of 4.79, a relative unestimated risk of 3.6, the same for E2 NOMAC, an APCSR 2.6, and an estimated risk 1.7, and for E4 DRSP, we have an APCSR of 2.3 and an estimated risk of 1.5. So this is interesting because it can really provide an information on the potential risk of thrombosis. How can we explain that, especially for E4? We already discussed the pharmacological properties of E4 and the fact that E4 is an antagonist of estradiol regarding the membrane-initiated signaling pathway. It is very interesting because we know that the liver is responding from both nuclear and membrane stimulation. So it means that the low effect that we can have on the membrane and on the nuclear effect may explain the low impact of estetrol on the hemostatic system. Just to permit you to make the comparison, these are the thrombin generation curves from the safest 18-estradiol containing product and E4-DRSP. You can see that the changes that you are inducing with 18-estradiol levonorgestrel is clearly higher than the one that you have with E4-DRSP, whatever you are in the condition in absence of in presence of activated protein C. Interestingly, data from the phase 3 study supports this assumption. From the clinical trials, only one single venous thromboembolic event over more than 3,400 participants in the US, Canada, and European Russian studies were reported. This represents an incidence of 3.7 per 10,000 women year. And if we look at the estimated incidence coming from the model and considering a baseline risk of 2.4 per 10,000 women year, as with the latest epidemiological studies evaluating the risk of VT in non-user, we can have an estimated incidence from the model, which is very close to the one observed in clinical trials, which was 3.8 per 10,000 women year. In comparison, other products containing 18-estradiol that which were developed during the similar, I would say, the similar time frame than E4-DRSP demonstrate a quite higher number of venous thromboembolic events in the clinical development. Either it has been a combined oral contraceptive, a vaginal ring, or a patch. So the key facts. Hemostatic biological data and also early clinical experience with E4-DRSP are very reassuring. E4 is a safer compound in contraception, and in my opinion, data from the past, I also worked several years at the European Medicine Agency, and data from the past studies will support, obviously, and provide real-life estimate, but they will not be able to characterize the risk. We already have all the explanation regarding the physiopathological pathway that lead to an increased risk of VTE with 18-estradiol. We know that with E2 and E4, we have a lower impact on this physiological pathway, so we can really rely on these data showing that we have a lower impact on hemostasis and therefore a lower risk of VTE. So my final words is that we also need to take into consideration that a pass will take more than 7 years to be issued. The pass is there due also to regulatory standards following the risk observed with 18-estradiol containing product, and this means that all new combined oral contraceptives need to conduct a pass. Whether there is a risk or not, whether you are presenting very good pharmacological data, even if you don't have an impact on the liver at all, because you have an estrogen, you will need to conduct a pass. Thrombosis is a multifactorial disease, and also you have to know that non-interventional paths are not always able to capture all the risk factors, and they are not always adjusted for that. So having smaller studies in which you are able to clearly characterize the risk and capture all the confounding factors are clearly more important in my opinion. And also a simple tool like the NAP-CSR is able to characterize the impact of a particular combined oral contraceptive on hemostasis, and it is linked also with the risk of VTE observed from very large epidemiological studies. So and it is just my last words, but we are also discussing with the innovative task force from the European Medicine Agency to make the NAP-CSR recognized as a predictive tool to better characterize the risk of VTE when we are developing new combined oral contraceptive. Just one last idea for potentially an ESG task force. The choice of the estrogen, we already mentioned that the choice of the estrogen matters when considering the risk of VTE. And I would think, I did a lot of intervention in the literature for that, but classification of combined oral contraceptive should be reappraised considering the latest scientific evidence. So I think it's time to revision. I thank you very much for your attention.
So thank you very much, and thanks for the suggestion for action. Please remember to post your questions in the Q&A box, and it's nice if you state your name. You can also state for which speaker your question is intended. So, and all speakers up to now will be present for a live Q&A session. But we have a last speaker, and unfortunately he will not be present, but you can still ask questions related to his presentation. So the last speaker is Professor Tommaso Simoncini, and he's a professor of obstetrics and gynecology at the University of Pisa and head of the OBGYN division. He's the scientific director of the Molecular and Cellular Gynecological Endocrinology Laboratory, which focus on molecular effects of sex hormones on cardiovascular cancer and brain cells. His clinical research spans endometriosis, fetal growth restriction, pelvic floor diseases, with a special focus on robotic and minimal invasive gynecological surgery. He has published numerous scientific publications which are highly cited and with great impact. And he is the president of the International Society of Gynecological Endocrinology and the executive secretary of the European Society of Gynecology, and board member and past president of the European Menopause and Andropause Society. He's also a fellow of the International Academy of Human Reproduction and associate editor of Maturitas. And his presentation today will be hemostasis, it will be a new horizon in combined hormonal contraception and beyond.
Thank you, Kristina. Thank you to the previous speakers. So it's my task to introduce potential things that we will have very, very soon with this very interesting new estrogen. And these are my disclosures. And in trying to recap what has been just said by the previous speakers, I think that there's some messages that help us clinicians understand why it's good to have a new estrogen in our field. First is compliance. As we've heard from the first presentation from Kristina, women really want combined hormonal contraceptives that meet their needs, and they don't bother them. So the estrogen matters to this extent because we've seen how side effects are important. And it's particularly cycle control that is very relevant. Women are really bothered by irregular, unscheduled, unwanted bleeding, and also bothered by the absence of the withdrawal bleeding. Many women like that, want that, and that is why it's very good in terms of acceptability that the combined oral contraceptives keep the promise they make. I'm gonna make you bleed every month regularly and lightly mostly. But there is also more. We've heard about the metabolic impact. So metabolically speaking, we are physicians. We're very worried about the impact of our treatments onto women. So it's very important to be aware that there's differences. So different estrogens have different impacts on metabolism. And this is important in the long term and in some women particularly. So to this extent, we've seen how the combination of E4 and drospirenone has minor metabolic effects. And VTE, as we've heard from Jonathan in this last presentation, is absolutely and has always been the most relevant worry for us physicians when prescribing combined hormonal contraceptives. So therefore, having a way to escape all those hemostatic problems we've learned with ethinyl estradiol, with new strategies with changing estrogens particularly, and estetrol, as we've seen, it might be a very good strategy to minimize because of its low liver impact. So, to make a long story short, it's good to have Estetrol, and it's good for contraception because it gives us a number of options that we didn't have before. And you've understood perfectly now, because of this symposium and others you may have listened to, that Estetrol is very similar but also different from the other estrogens, not just because of this backbone, it's the same, but it's because of this hydroxyl group, and it has this 4 because it has 4 hydroxyl group. So there is a biochemical difference in the molecule that makes it very peculiar in terms of its actions. I'm not going into speaking about receptors. You've heard that. Franca discussed that and the relevance in animals, in cells, and also in the clinical field. But I'd like to drive your attention to one of the aspects that is less understood or less appreciated so far. So these biochemical properties of having this hydroxyl group makes Estetrol different in terms of metabolic paths. So it's not a substrate for cytochrome P450 enzymes, which means it's not degraded as the other 3 main estrogens, estrone, estradiol, and estriol. And this is very important, and is probably more important than we think, particularly in some tissues, like in breast tissue. Franca has mentioned several preclinical evidence on cells and animals on why Estetrol might be less active in the breast or differently active in the breast as compared to estradiol. But the fact that it's not metabolized to some of those kinones and catechoestrogens that can be obtained through cytochrome P450 metabolic changes attributed to the other estrogens, it's relevant because we know that some of these are carcinogenic. So this is another example of why it's good to have another different molecule, which might mean that in the breast we might not just have been able to modify the receptor and activate the receptors differently, working in the nucleus or in the membrane. We've heard some messages, but also because of lack of metabolic transformation into carcinogenic molecules. So this adds to our preliminary knowledge, because this, all the data that we have so far are very, very preliminary compared to the vast amount of knowledge we have on estradiol and on the action on the different receptors in a different sites of our body. But we do appreciate, because of the growing research we have, that there are some tissues where it really works differently, and the breast and the data that you've heard in a previous presentation do support that, is one of the tissues. And it's probably because of the different ability to interact with receptors and do the same things that estradiol does in breast cells that might make a difference. So why should any woman care about this? So is this important? Because this is all very molecular, very cell-based rationale. Is it important? It is probably very important when we think about what I'm going to discuss now. So Estetrol is being so far available to us as a contraceptive in combination with drospirenone, but very soon we will have it also as a menopausal hormone therapy. So Estetrol can also be used, and I will show data about that, to address menopausal complaints. So when we think about the recent history, and it's now not even that recent now, it's 25 years nearly that we know how the history in menopausal care changed because of the publication of the Women's Health Initiative trial. There has been a major drop in the use of MHT by women because of the data on breast cancer incidence, which really drives the skepticism and the fears of women and of physicians in prescribing MHT, even to women who deserve MHT because they have symptoms, and maybe also to prevent degenerative disorders. And it's very unfair to women because we know this data that you see graphed here in one of the many tables that you might find over the internet. This comes from the British Menopause Society, but there's many examples of these tables that exemplify how the additional risk of breast cancer induced by a combined estrogen plus progesterone, and it's actually mostly based on CE plus MPA data, for 5 years in postmenopausal women compares in terms of incidence to many other modifiable risk factors which are never on the table of discussion. Smoking, drinking a reasonable amount of alcohol every day, being physically inactive. And on the other side, it's never said that when you have estrogens alone, for instance, without MPA particularly, women are actually getting a protection from breast cancer. So if women and physicians were more aware of the size of the effects we are discussing, we would never have run into the disaster of the communication that after the WHI, all the women's health field received. But nonetheless, it's very important to remember where we start from. So there's a huge skepticism in the medical area and in women towards estrogens. So it's very good to have new estrogens, particularly when they come to us with preliminary data, I would admit that promise though and encourage us to do research into their potentially lower effects on the breast. So to this extent, there has been a long clinical development program for the use of Estetrol in menopause that started in the early 2000s and is now led to the publication of phase 2 studies, which I will show in very simple slides, and now to phase 3 studies. And for instance, the E4 Relief phase 2b trial was a study that was meant to address the ability of Estetrol to relieve the main problem of climacteric women, vasomotor symptoms. So is this estrogen going to be useful to address hot flashes in women after menopause? So you can see that this was a study with 257 women, and they were treated with 4 different amounts of Estetrol, and those women who had a uterus was the majority of the group, then they received also a treatment with a progestin later on. So in terms of efficacy on the primary outcome, which is vasomotor symptoms, you see that the study shows that with 15 milligrams of Estetrol, you get a significant and solid decrease in terms of frequency of vasomotor symptoms, with a profile that is very similar to what we know from all the registration studies from other MHT. So within a month, you reach the steady state result, the maximal reduction, and then you keep it going. So it's very similar to that extent. And severity as well. So this study served to demonstrate the efficacy and also to establish which was the most effective dose that has been then taken up for future development into phase 3 studies. And then the other part of a woman's body that is very often in need of being re-estrogenized after the menopause is, of course, the lower genital tract, the vagina. Women suffer from vulvovaginal atrophy a lot. So we need to understand whether Estetrol is going also to be able to address that complaint, which is very important. So again, here in the same study, you see that while increasing the dose of Estetrol from 2.5 milligram up to 15 milligram, you have a significant change, particularly with a higher dose, in the amount of parabasal, intermediate, and superficial cells, which means that you are regenerating the more physiological or younger type of vaginal mucosa structure with a clear estrogenic effect in the vagina. And when you ask women whether they feel like having less GSM symptoms, including the perception of vaginal dryness or the pain associated with sexual activity or itching and irritation, at least with vaginal dryness and pain associated with sexual activity, you have a clear, significant result. So these data show us that we can use Estetrol 15 milligram to alleviate the most common clinical complaints that women experience after menopause. And in the same study, and I'm not showing the data for the sake of time, but it's very similar to what you have seen for the coagulation story. It's just a different type of woman and a different amount of Estetrol. So you see that there was no impact on coagulation markers, lipid, glucose metabolism parameters. HDL cholesterol was better, and glucose metabolism got better. There was a reduction in bone metabolic markers indicating resorption, which is potentially positive and is an estrogenic effect. And with the endometrium, you have, of course, an estrogenic effect. So you see an increased thickness in the endometrium if you provide only Estetrol. But then this is counteracted efficiently with a progestin. So to summarize, we know that menopause has a significant impact on quality of life and health. This is, of course, our meat every day in discussing with patients. We do remind ourselves that the guidelines support the use of hormone therapies as the first-line strategy to address menopausal complaints. But we have different types of estrogens now, and in the future we will have Estetrol as well. And to this extent, the phase 2 studies highlight how this will probably be a useful tool to address VMS, vaginal pain and vaginal dryness, and it's a new option again. So we're getting beyond contraception and expanding towards menopause, and all of this, I think, is very good. So thank you for listening to me.
So then we will move on to the Q&A live session. And now I hope that the speakers have joined. So we will have Professor Fruzzetti, Professor Piltonen, I can see already on the screen. Welcome. And yeah, Professor Fruzzetti, welcome. And then I will move this box, and Professor Douxfils, excellent. And thanks to those who have posted questions, and you still have chance to write your questions in the Q&A box. So I will start with a question. I think this is to Professor Fruzzetti. So your opinion about the use of the so-called bioidentical hormones?
Oh yes, bioidentical hormones are quite similar to obviously natural hormones. I think that there is some confusion about the name, the terms used, and actually they are very similar, though, so they can reflect the action of estrogen that we know very well. So the main difference is that now you know everything, I think, about natural estrogen, 70 beta, estrogen, and so on, but we have only less information about the so-called bioidentical hormones. So, in my opinion, natural estrogens are more safe than bioidentical ones.
Thank you very much. Yeah. So, anyone who would like to add to that, or do we all agree? Yes, I think we do. The next question is, so this first was asked by Marvin Akvede. I'm sorry if I don't pronounce it correctly. The next one is unfortunately anonymous. Person who asked if E4 is not metabolized through cytochrome P450, it may be a good idea to use E4 in epileptic patients treated with induced drugs. Jonathan, what would you answer to this?
Okay, can you hear me correctly?
Yes.
Yeah, okay, perfect. So I think it's in fact a good idea for the estrogen component of the pill, but here we have to consider the fact that we have also drospirenone into this combination, and drospirenone is also metabolized by CYP3A4. So I think we still need to consider that we can have an interaction with drospirenone. But considering, and there is a very interesting pharmacokinetic study which was published in 2020, which demonstrate that even if you are using a strong inducer of CYP3A4, the profile of drospirenone is not so bad compared to other progestins. So I think we need more data before to have a clear conclusion. But here, clearly E4 has an advantage for the estrogen component. Drospirenone is not so bad, but we will have an interaction with a decrease in the exposure of drospirenone, and so a reduced efficacy of the pill.
Thank you. So then I will ask a question. And we know that now EU is looking more into endocrine disruptors, and the impact of estradiol especially is one of them, and the impact on environment. So Terhi, Piltonen, would you like to say something on E4 versus EE when it comes to the effects on fishes and environment? I mean, both external and internal.
Yeah, thank you, Kristina. And this is a really important subject, as we know that we need to be aware of the steroid hormones that are also passed to the nature when we have been using them and when you are using them. There are a couple of really nice new studies that have been actually looking at the effect of E4, and they have been comparing them with the estradiol and also EE, and I think the results are really reassuring. There were no major defects. Similarly than with the other estrogens, you would really have to go with the very, very high doses to induce any alterations in the fish, as is usually the setup where we are assessing these steroid hormones for the environment. So I think it's reassuring, and I think here, thinking about the metabolites and thinking about the estrogenic effects of E4, thinking that there was somebody was asking what was the ratios or the impact on the on estrogen receptors. So the E4 is 1/16 of E2, whereas E2 is 1 out of 100. Or EE is 100 more potent than the natural estrogen. So the E4 is even less potent than the natural estrogen, estradiol. So in that sense, I think it's really assuring, and I think this most likely will come more in front line in the future.
Oh,
we start having.
Thank you. Thank you for answering that question that related to my presentation. I tried to illustrate it, but that's exactly what you said. And I think also important for the environment that there are no active metabolites of E4. But I was also thinking about what Jonathan Drophy referred to, that drospirenone is actually compared to levonorgestrel, which is that is the gold standard for the regulatory agencies, but the toxicology of drospirenone is much less than that of levonorgestrel. And I mean, Jonathan, you're the one maybe explain that better than me.
No, I fully agree with what you are saying, and I think it's also important not only to consider the estrogen. We have a very good opportunity here with Estetrol compared to ethinyl estradiol, because we can change the estrogenic component. But the fact that we have also this association with drospirenone is really good. And I think the key message is that for the first time we can use this very interesting and very efficient progestin which is drospirenone in a safe way by putting it with a good estrogen. I think the main issue with drospirenone was that it was used with estradiol, and we have this bad message around drospirenone containing pills, but we have to keep in mind that it is drospirenone associated with estradiol, and drospirenone associated with estetrol is totally different.
Extremely important. So, but I think here, I mean, as Franca said, so we have a natural pill, maybe in a way, but also a green pill, which I think is important. So if we move on to the next posted question for Terhi, I think, what is the effect of E4 on endometriosis?
That is also interesting question, thinking about what do the women with PCOS, what do they benefit from? So they would benefit from a preparation that would have regular cycle control, but also that they would definitely benefit from amenorrhea. So here I would say that yes, we know that there are studies showing that the for example menstruation-related pain is decreased with the E4 plus drospirenone pill, and there is, if you are with some other pill and then you transfer then to you switch to use this pill, there is no change in the pain perception. So on the other hand, we know that it's kind of a safe to switch, and the women do experience less pain when coming for on this pill if they haven't had any combined contraceptives. We do not know how these pills work continuously. It might be that there need to be some more studies, or we need some more experience, but definitely the cycle control and the pain relief just on itself when coming onto these preparations would be good. And then I do not, maybe Kristina, you know whether there are any studies on endometriosis lesions. On I think there are some studies now, maybe you could refer on them.
Yeah, or Jonathan, do you have any
Yes, there is
information on
studies in Japan which demonstrate that there is a reduction in severe pelvic pain, and also there is a very, very interesting data which were more based also on laboratory investigation, in which they demonstrate that E4 could suppress the migration and also the invasion of endometrial cells, which are key factors for the development of endometriosis. So I think E4 can really reduce the inflammation and also modulate the oxidative stress in this condition. So I think these data are very, very reassuring also with E4. These are data mainly in Japan.
So I agree. So it's both symptomatic, but actually also an effect on the lesions. So that's promising. But Terhi, you mentioned PCOS. So if we move on to effect of E4 on PCOS.
Yeah,
for me.
so
no, Terhi.
sorry.
I thought because Terhi mentioned it.
PCOS.
Yeah, you can all
you are more the
address it,
expert
but we
for
start
PCOS
with
than me.
Terhi. Yeah.
Yeah, so thinking about these women that are on a metabolic risk, and they definitely need combined contraceptives for their skin issues, acne, and then also hirsutism. We know that these preparations, or this one with the E4 and drospirenone, it does not reduce that much of an SHBG, but if you really look at the data, it is quite potent still to be able to reduce the free androgen index. So I think we need more data on the clinical outcomes, but I would assume that this could be a good pill to start with, for example, because we know that many of the combined contraceptives are efficient, and here you would even have the metabolic effects for the women, thinking that they do carry this metabolic burden as they have adverse metabolic profile and also this low-grade inflammation. And here I would assume that these preparations do not trigger that much of an inflammation as the EE-based combined contraceptives. So I would say that in a long term, these could be considered very much to treat women with PCOS, but I call more research on this.
Yes.
Yes, I completely agree about this point, because mainly in PCOS with the cardiometabolic compromission, the use of this kind of association, mainly because also the presence of drospirenone, I think that may play a very good role.
Yeah.
I agree.
Yeah.
And Jonathan, also when it comes to APC resistance, metabolic risks, as Terhi mentioned, also for PCOS.
We know that ladies with PCOS are more at risk also for cardiovascular disease and so on, and therefore the effect of E4 is really reassuring based on that, because not only of the reduced risk of VT and its impact on APC resistance, but even if you are considering hypertension, the association of E4 with DRSP is quite reassuring as well, because we have a low impact on the liver, and so a low impact on the renin-angiotensin system, which is quite interesting because we have also a mineralocorticoid effect with drospirenone. So in normal high hypertensive ladies, we have also data demonstrating that it can normalize and at least reduce in a clinically significant way the blood pressure. So this is really, really reassuring.
I agree. I mean, this is potentially something that people will use for a long time. So even if they are within the sort of normal range, if the blood pressure is reduced, which we'll see in the clinical trials, I think that's really a potential health gain. So that's very promising. Now we also have a question related to hormonal treatment and surfing into the menopause. And do you think that E4, I mean, when can we expect E4 for hormone therapy? No, Tommaso is not here, but anyone who can look into the future?
Ladies first, but I can speak after, especially regarding the safety profile of E4 in this indication. But especially if we are discussing the safety, what we have observed with E4 in association with DRSP is practically the same with E4 alone, meaning that we have a low impact on the liver, and we have also a low impact on the hemostatic system. The metabolic profile is quite reassuring. In fact, what we can have with E4 in terms of impact on coagulation proteins and on the hemostatic system in general is exactly the same as the one we observe with transdermal E2 at the dose of 50 micrograms. So this is really, really reassuring for this indication, and I think that the efficacy results are also in a good way. So meaning that we have the effect that we expect with E4 in this indication. So I think it is it is really maybe. I can maybe say that in this way, but it can be a game changer in this indication compared to what we have currently on the market.
Franca, would you like to add? Yeah.
Yes, also data on hot flashes and other vasomotor symptoms are very, very exciting. So I think that there will be a place in the market for this kind of estrogen, also for menopause. Yeah.
And the
I think it's Kristina's.
Yes,
there
is
but I think we can wait until she will. Yeah.
Okay.
Okay. Now
you're back, Kristina.
Okay.
Yes, I'm sorry, something happened. Did you hear my question?
No.
So what I asked was
connection.
No, for E4 for HT, what would you recommend when it comes to the progestin, which
yeah, I think that's an interesting question, that what would be the progestin, and here again, if we think about the metabolic profile, women will get more androgenic, you know, when they you know, grow older, they are losing their own estrogen. I think it's even more important to maybe boost up a little bit the estrogenicity. So here again, the drospirenone most likely will serve really well. So I think we are coming to the era where our contraceptives are actually now maybe a transition to a menopausal hormone therapy. So yeah,
exactly.
so I think that's what we can see maybe here, that you'll start with the preparation that you can actually use until quite long time.
Yeah, I agree.
I say I agree.
And I think it's
fully
also important because in the clinical trials, I mean, the upper age limit was 50 years. So not, I mean, in many clinical situations, women above 40 are told that they should stop with their combined oral contraceptive pills. But actually, that's based only on age. And now we have the clinical trials going up to 50 years. And I think here there is really a chance to continue with an effective and safe method, because what we can see from the abortion statistics is that while teenage abortions are going down in most EU or European countries, abortions among those above 40 is actually going up. So
I think you're absolutely right that many of the women are looking for alternative ways to have contraception or execute their contraception. And here we know that many of the women would also benefit on adding estrogen now when they are premenopausal. Many of the women will definitely have premenopausal symptoms. So I would say that this most likely would be one of the answers, that we can improve quality of life without having high risk for other adverse effects.
Yeah, so I agree. I think this will be a game changer. And this question was asked by Anke Bössner. The next one that Terhi already answered was posted by Wendy Wolfman. So I hope that you understand now this difference. And this is especially when it comes to the effect on the liver, where E4 has much less impact. Yeah, the next question is, of course, important also by Natalia Maslenikova. Is there any data about teratogenic effects of E4?
Yes.
Yeah, please.
Franca.
Please go ahead.
Yeah. I think it's it's an interesting question, because E4 is produced also by the fetal liver. So up to now, we have no data, either animal data or whatever, or human data, indicating any teratogenic effect of E4. Obviously, it's always the same when we are discussing a product, but we don't have data in pregnant women. It's logical based on the profile of the product, but no data in animal studies or any other, I would say any other indication may suspect any risk of teratogenic effect with E4, and also based on the product, it's not possible. It's not the same as the story that we had with diethylsilbestrol, for example, for which we had bad data. Here, it's not the case, and also the fact that we have to think that based on the pharmacodynamic profile, it's totally different as other estrogen. I think we have no risk at all up to now, and no data are supporting that.
Yes,
and actually, E4 is produced during pregnancy.
Yeah,
and
during pregnancy, at very high levels.
Very high level, corresponding to 55 milligrams per day.
Yeah.
And what we give in the pill is 50 milligrams. So I think based on that, we can really rest assured that
be
this is
reassured.
safe.
Yeah, I agree.
A completely different scenario from diethylsilbestrol because pharmacological,
it's totally different. The pharmacological
and this is endogenous, so it is quite.
And again, going back to what you said,
only during pregnancy.
So I mean, a natural estrogen.
But modern is produced by the fetus, is not teratogenic from.
Yeah, for the features, it's poised so
Yeah, so every fetus is actually already exposed.
to E4.
Yeah, to E4. Good. So we thanks. It's nice. We all agree. Now, the next question is from Dr. Ximena Zurita from Ecuador, who thanks for great presentations, and I agree with her. And that it was well explained about a good cycle control with E4 drospirenone. And my question is about your personal experience in real life. So then if we start with Terhi.
So I think the data, we were the biggest data collector actually in the phase 3 trial in Finland, and the women really had good cycle control, and many of the women wanted to continue with the preparation, but of course, you know, we were not able to provide it as it wasn't in the market at that time. But I think one of the main benefits was that it was very, in that way, trustful on the bleeding profile. So I think that was very good. On the other hand, sometimes when you have women that have lots of bleeding profile and they come to your office because of a bleeding profile, especially if they are young women, we know that these women need to be treated with the high doses of estrogen. So there you might have some problems, but I think, you know, in general, the bleeding profile is very good. Some of the women actually become amenorrheic even when they have the placebo pills. Now, of course, you know, the company is not able to recommend, you know, continuous dosing, but we have been trying it, and for some women it does seem to be working. But it depends. If they are very young, it might be that for a while, you know, it might be that it doesn't, that you need to come and have bleedings now and then. But I think in general, especially if women are using the placebo tablets, the bleeding profile is very good.
Mm-hmm. Franca, do you agree?
Yes, I completely agree. Also, because from the clinical phase 3 studies, at least in my clinical experience, my experience is very, very good. At least in the appearance or the irregular menstrual cycle, it is a very important. This because actually women come saying, oh yes, my cycle is regular, I have my menstruation and so on. There is in some women the problem of spotting may be present spotting, so but is always very, very light. So actually I have a very good experience also in this case. Yeah.
And I agree with you. And I think also, although, I mean, it's off-label, but I mean, nowadays, many prefer long cycle treatment without any interruption. And I think in most cases, this works really well. I agree with Terhi that sometimes in the younger, they will need breaks and bleeding. But otherwise, I think that's really something that can be tried in those who prefer.
And if I can add something regarding the data that we have collected so far in the ultra-vigilance database. So we are just in the way of publishing these results in the scientific literature. I hope it will be available soon. But what we have collected as data from real life experience is that we have a lower reporting rate of VTE with E40-RSP compared to any other combined oral contraceptive, even those containing estradiol. And I think it is really, really important because it means that considering the risk of VTE, there is a lower frequency of reporting adverse event related to VTE with E40-RSP compared to any other combined oral contraceptive. And I think it's really an important message because it goes in the same line as the data that we have from biological data and clinical evidence from phase 2 and phase 3 clinical trials. So even if we are waiting for the post-authorization safety study, all the data that we have so far in the pharmacovigilance database are very reassuring regarding this product.
Fantastic, and in line with your studies. And I think Of course, safety is extremely important, but for compliance, we know that bleeding pattern matters very much. So this taken together is really promising.
We come together.
So now, so the next question is a little bit in line with what was already asked, and this is from Alvaro Monterosa Castro. Are studies of combined hormone therapy for menopause ongoing? Yes, they are. With which progestin? And in which scheme? And he's from Cartagena, Colombia. I don't know, Jonathan, could you answer this?
Not really. I'm not in charge of this type of patient, but because I'm
no, I thought if you were aware about the clinical trial.
But about the clinical trial, yes, in fact, the progestin that was used was progesterone. But we were discussing here, especially in non-hysterectomized ladies, and it was also discussed some months ago that maybe it could be of interest to think about continuous treatment with E4-DRSP. And I remember that at that time I was saying that you can or you could probably use E4-DRSP from 16 to 66 just for just to make it clear. But I think maybe in the future it could be the case. So here in the design of the study, they were using a progesterone when it was necessary in non-hysterectomized ladies, and in hysterectomized ladies they used only E4 alone.
Thanks. Yeah, and then endometriosis, adenomyosis, I think that was already answered. Is it safe to prescribe directly? Yes. I
regarding the safety, regarding the safety, definitely yes.
Yeah.
And also regarding the efficacy.
Good. Then the next question is that Patino and co-workers in 2023 showed in vitro that E4 increases progesterone response. I'm not so sure in which way.
Yeah, I'm not.
Jonathan, do you think or Terhi?
Yes, I think as with the other estrogen, there can be an effect on the on the response of progestin because there is an interaction between the two systems. So this is something that is well known regarding estrogen, and E4 just confirmed this effect as well.
And I think maybe here we can touch upon again the bleeding profile that you know here the working together with the estrogen that the estradiol really, or I'm sorry, the E4 as well as estradiol, all the estrogens will now increase the expression of progesterone receptors. They will stabilize the endometrium, and here especially without metabolizing, I think, you know, in that way also I think that might explain some of the endometrial stable.
Yeah, that 17 beta HSD, as Franca explained. Yeah, it's not.
Yeah, but also in endometriosis is one of the mechanisms that may play in case of endometriosis to increase the number of progesterone receptors. So this is good, sure.
Yeah. Yes. The next question is very interesting. It's actually a patient group that I've noticed in my own clinic now. And the question is, could E4 be a good option for BRCA positive patients? So patients with BRCA mutation, which we know will increase the risk for breast cancer and also ovarian cancer, depending, of course, on the type of BRCA mutation. But so what do you think about this? Franca, do you want to
think that at present time? Okay, no.
Franca, go ahead.
At present time, you cannot give an answer about this because we can say as all the other oral contraceptives in BRCA are positive. But until now, I think it, at least in my opinion, is too early to propose a particular effect or different on the mammary gland. So the in vitro and some preliminary data also in humans are showing a very protective effect, but it's too early to suggest in our clinical practice, I think, to be particularly devoted to this of women.
Yeah. Thank you.
I agree, and especially if you are considering the pharmacodynamic profile of E4, we know that based on the pharmacodynamic investigations, we have an antagonist effect on the membrane estrogen receptor when you try to stimulate this membrane estrogen receptor with E2. So we have an antagonist effect. So these are very interesting and promising in vitro data, but obviously we need to have more data before putting
studies.
before putting it into the clinic in this indication.
But potentially very interesting, and of course combined pills will also prevent ovarian cancer. So in that way, it makes sense. So the last question is: can we infer that time of prescribing E is ending? I think what we could say is that estrogen matters, and I think it's time to change our clinical guidelines based on the data we have already. And I would like to conclude with thanking all the speakers, thanks to those who have posted questions, and to remind us that the power of the pill is still as strong as it was 60 years ago, but the expectations of today users is different, and that's why we need this new option. So thank you very much.
Thank you very much.
Thank you. Thank you.
Thank you. Have a good day. Bye-bye.
Bye. Bye.
Bye-bye.
Nice
Goodbye.
evening. Bye.
Nice to see you.
Bye.